Hi, everyone. Thank you very much for coming today. My name is Ashley McPhail, and I am the Chief External Affairs Officer here at the Texas Medical Center. We're very excited to host this Houston Neuro Summit. The summit today will cover a number of topics of, sort of why neuro, why now, what does that mean? The impact that we've seen from CPRIT, both on the research, health, and commercialization, and a broad number of experts that you will hear from. So first, I would like to welcome all of you. To the legislators and their teams here, thank you for coming. We appreciate your support as we are getting ready for the next session in 2025. And then, of course, to the Houston Neuro community, everybody from the institutions who are here, as well as the clinicians, advocacy organizations that work within this space, and policy experts. It takes all of us coming together to really make an impact in this field, so we appreciate you making the effort today. I just want to give a little bit of a quick overview on the Texas Medical Center. So the Texas Medical Center is 60-plus member institutions, all here in Houston. And that's everybody from the hospitals, the academic medical centers, to the universities and research groups, as well as a number of support organizations as well. Houston, for the past 75 years history, is a leader in the clinical and research space. And then since 2015, when we launched the TMC Innovation Factory, has really started within the commercialization space to think through how do we take things from the lab and get it into the hands of patients faster. And so that's a lot of what you see going on in this building and across this TMC Helix Park campus. So a little bit, I just want to sort of set the stage, why neuro and what's bringing us here together. So if we think about it, there are over 400 neurological disorders that constitute when people think of neuro diseases. A couple of these on the board, from Alzheimer's, dementia, to PTSD, to strokes. Neuro diseases impact everybody and all of their families. And so when we're thinking about that, 70% of Texans will develop a neuro brain ailment. And so this can be something, means everybody's family is dealing with this at some point of their time and building that out. There's 15% of the health loss worldwide is due to brain disease. So when you think through, of course, not only is it a personal health issue, but the economic impact as well. Texas is, of course, home to over 1 million veterans. That is one of the largest state of veterans. And of course, the PTSD and other trauma and things that impact our veterans is top of mind when we think through this. And then, of course, Alzheimer's that we've heard a lot about. Over 400,000 Texans suffer from Alzheimer's. Texas is the fourth in the country as far as the number of people impacted, and second in the number of deaths from Alzheimer's across the United States. So again, just that impact that everybody and their family feels. So today we are really here. We're going to start and have two great experts really talking about their journeys with both CPRIT and the CPRIT and the impact that that has had since it was founded by the state years ago, and then as well as a commercialization. So how a startup has really been able to accelerate with the help and support of CPRIT. And then from there, we're going to have an expert come in and talk to us on sort of why this is the time for neuro. What does this mean for brain health? How do we get everybody involved in all the different areas from it? As well as hearing from members from all of our institutions on two different panels. And so we're looking forward to this day. We'll also have time for a bit of networking in between and after. And hopefully we'll have a few more people join us throughout the day in between some research and clinical that they're also doing on campus. But thank you for being here. So with that, I'm going to introduce Kristen Doyle. Kristen is the CEO of CPRIT. So for those who aren't quite as familiar, but the Cancer Prevention Research Institute of Texas. Kristen took over the CEO position this past July. But before that, she was the Deputy Executive Officer and General Counsel. She's been hugely instrumental in helping CPRIT really run from the regulations, the policy, and ensure that the highest standards are done so that CPRIT can make the most impact when it gives out the awards and accelerates cancer cures and treatments. Prior to joining CPRIT, Doyle was a partner at Austin-based law firm within the energy sector. But she's been a great partner to TMC, to the institutions, and we are excited to have her here today. So welcome, Kristen.
So let's see, okay. I think my microphone works. Okay, so I'm Kristen Doyle, and I am thrilled to be here. I kind of feel like I'm the opening act for the main show. I'm really excited to hear about the neuroscience and everything that you will be doing. But I feel like it's a great opportunity to talk about what Texas has done already when it really puts a stake in the ground and says we are going to take on this huge, audacious challenge. And that's what we did in 2007. The Texas legislature created the Cancer Prevention and Research Institute of Texas and committed up to $3 billion. We also had a statewide vote. So we amended our constitution, vote across Texas to support the creation of CPRIT. In 2019, we were reauthorized with an additional $3 billion. So today we are a $6 billion research initiative that invests in cancer prevention and cancer research at institutions, community organizations, and companies all across Texas. So I'm going to tell you, what that has meant, what 15 years of continued consistent investment by Texas has meant. One of the things I said, we're $6 billion. We are the second largest public funder of cancer research in the United States. So we're only behind the federal government. And we are one of the top 10 public funders of cancer research in the world. And that really has put Texas on the map and has incredibly accelerated what is being done in cancer and the state's reputation from bioscience. So that's why I was thrilled to hear about all of the legislative interest that is coalescing around neuroscience also. So I talked about how, we're 15 years in. The constitutional amendment was passed in 2007, but we officially opened our doors in 2009. And I started at CPRIT July 20th, 2009. We opened our doors on September 1st, 2009, and made our first grant in November of 2009. So we've been doing this now for 15 years. We have granted more than $3.7 billion in 2,000 grants to, 151 institutions, companies, and community organizations all throughout Texas. Money only goes to Texas. We can put our money into, like I said, cancer prevention and research. So 10% of our money can go to cancer prevention. I'll talk about that first. We can prevent up to 50% of the cancers that we have now. So investing in screening and education and survivor resources, in tools that help people quit smoking, quit tobacco use, reduce alcohol use, vaccinations, genetic testing, all of those things can help reduce the burden of cancer. It also has been very helpful for us because we can touch every county in Texas. When we talk about research, you guys know where the research is being done. It's being done in Houston, Dallas, Austin, San Antonio, and then once you get further out, there's research being done in Lubbock, El Paso, the Valley, but there's many, many, many counties who don't have research happening there. So being able to touch every single county and really making a difference in those counties for cancer has been instrumental for us. So to date, we have been able to provide more than 10 million services. About 3 million of those services are screenings. With those screenings, we've been able to detect more than 46,000 cancer and cancer precursors and navigate those people to treatment. More than 441,000 Texans have received their first cancer screening through CPRIT. We're making real inroads in terms of HPV vaccinations and hepatitis B vaccinations. So these are all projects that started small. Our first years, we would be funding projects, so out of Houston that would serve 12 counties. And as they are developing innovative preventive systems and operations, then we're expanding those grants to include 36, 48 counties all throughout Texas. And we're really seeing that impact. But where we are making the biggest impact on Texas is in our research portfolio. So 90% of our funds can be spent on cancer research. And that cancer research happens not only at the research institutions and the universities in Texas, but it also happens at companies. So CPRIT can fund early stage companies also. So I'll focus first on the academic institutions and the research that's being done there. That's by far the largest portion of our portfolio. To date, we've funded about $2.5 billion in research grants to surprisingly 41 institutions all throughout Texas. And some of our kind of capstone awards that we have made and where we're really seeing how it's paying off now are our recruitment awards, so our CPRIT Scholar Awards. And this is where we can help institutions recruit some of the best and the brightest all throughout the country and even from around the world to come to Texas, bring their labs, bring their research money, and then plant themselves with our home team talent and really create centers of excellence. So to date, we have funded more than 325 of those CPRIT scholars. And these are people all across their career continuum. In fact, 2/3 of our CPRIT scholars are what we call first-time tenure-track faculty members. So they are really launching their early careers here in Texas, embedding here in Texas, and then eligible to receive more awards from CPRIT. But we've also been able to bring established investigators. One that we always talk about, of course, is Jim Allison, the Nobel Prize winner. We helped recruit him, we helped MD Anderson recruit him back to Texas in 2012. And of course, he was awarded the Nobel Prize in 2018. And those are perfect examples of people that come and are working with the best minds already here in Texas and really putting Texas on the map in terms of innovative treatments, and the next, hopefully, cures and treatments that we're going to see for cancer. So I said that we've invested about $2.5 billion in those academic research grants. Those grantees then have been able to receive about $3 billion in additional research funding to support the projects that CPRIT's already funded. So they've been able to attract a whole lot of more money to Texas to fund their research. We've also seen, when CPRIT was created, there was one comprehensive cancer institute, and that was at MD Anderson. Now, 15 years later, there's 3 comprehensive cancer institutes. Baylor College of Medicine has been added, UT Southwestern has been added, and UT Health Science Center San Antonio now is a designated cancer institute. And the funding that CPRIT has contributed towards those institutions, we are an NCI designated funder, have helped them, in addition to all of the incredible work that they have done, attain that comprehensive cancer status. So not only is that good for the research reputation of Texas, but it's great for Texans also. More options for innovative treatments, more opportunities to really see the impact of what Texas is doing when it comes to cancer. But I also want to talk about what we do in terms of funding early stage companies. Because it's incredibly important to be priming the pump with all of the research that's being done at our top-notch institutions, but we need to pull that research out of the pipeline and get it into patients. And that's where the early stage companies are really important. We talk about in the cancer area, and I think that this is probably true for neuroscience also, but we talk about the valley of death. So there's a lot of funding when we're looking at institutions. There's pharmaceutical and venture funding, once you're phase 2, once you're showing some good data, phase 3. But there is this big gap of funding for these great ideas that really have nowhere to go because of lack of money, and so they die in the valley of death. And CPRIT established early on that that's where we were going to focus. We wanted to focus kind of those last stages of preclinical work and then early phase 1, phase 2 clinical trials. So to date, we have funded 74 companies. We've invested 770 million. We've committed 770 million to those companies. We have tranche funding. So we commit all of the money, but they have goals and objectives that they have to meet to keep unlocking the tranches of funding. We have, at this point from those companies, we have 5 products on the market, including a cancer drug that's treating renal carcinoma. And it has been incredibly beneficial, and we really see this in Houston in terms of the life science ecosystem that's being built here. We invest the money in the companies, but then there is a whole ecosystem that comes around, from manufacturing, from other early stage companies. TMC is a great example of these conveners of communities of incredible entrepreneurs, that are working with the scientists that we already have here to really be developing what Texas is doing best. And, we see that also, one of the things that we have committed to, I talked about, the early stage funding, about 12% of our portfolio goes to discovery research or basic science. But another thing that CPRIT decided early on was we weren't going to be, a mini NCI. We really wanted to fund, translational and clinical research, both at the institution and at the company level. And so at this point now, we have funded more than 300 clinical trials. We've treated 60,000 patients through those clinical trials. And certainly when it comes to cancer, for many of those patients, this was their last option in terms of innovative treatments. We really, obviously all of that has to happen in order to get these therapies out to the market and make them available for patients. So we're willing to take that risk with the academic institutions, with the early stage companies in these early phase 1 clinical trials to help them gather the data that's necessary in order for them to be able to attract additional funding. So I said we've committed 770 million to these companies. These companies in turn have been able to raise more than $7 billion in additional funding after the CPRIT investment was in. And that's exactly what we need to be doing. We need to be moving these down the pipeline. And it's a good segue. I really thought today, usually when I talk with groups like this, I'll run through, our statistics, the great things that we have done, but because so much of the audience is here for neuroscience and the possibility of what that could mean for Texas, I wanted to kind of give you my perspective 15 years into CPRIT. Like I said, I came to CPRIT in 2009. I left my legal practice. I was partner at a law firm. And the reason why I came to CPRIT was because I was diagnosed with leukemia out of the clear blue sky in 2005, right after I made partner. And it left me with a profound appreciation for everything that was put into place, decades before I even got sick, that, was able to type my leukemia, figure out that, I wouldn't be able to hold a remission, so fast-tracked me for a bone marrow transplant, and then all of the therapies that were available to help me deal with the side effects of that treatment and graft versus host. And so to be able to be part of this incredible initiative that was going to affect so many Texans and so many people around the world was just too good to pass up. But, we were sitting like you guys are now, with all of the hopes and dreams of, what could this be like? What could the difference that Texas could make? And so it is wonderful 15 years later to really see, what, the result of having those seeds planted. And you'll hear next from Sarah Hines. She's one of our CPRIT grantees, one of the companies that we have funded. But you'll hear her tell how, that didn't just sprout up out of the ground. It was, consistent work all the way through. We funded research at the institution. We funded training programs. We funded an accelerator that helped all bring that to the point where it was ready to launch into a company. And as I was thinking about what I was going to talk about, I thought about, what are some things that I think have been key to where we are today. And one of the most important things I'll say is our peer review process. And I really have to give credit to the legislature, because it was always written into our legislation this way, that any money that we are putting into any grant, prevention, academic research, product development, those recommendations have to come from an expert peer review panel. And we took it a step further. We recruit, all of our peer reviewers are from outside of the state of Texas. So they're not eligible to receive CPRIT money. And we tell them, you pick the best of the best. We want the best science. We want what's going to make a difference. But you look at this for, what do you think Texas should be putting its money in? And that has really helped us. We're a state agency, so our board is appointed by the governor, lieutenant governor, and speaker. You can understand how it'd be very easy to look at us as potentially a slush fund. Is the governor going to call up and say, hey, my brother-in-law's got a really great idea for curing cancer? None of that can be approved by our board. Our board can only take action on recommendations that come from the peer review. And a result of that is, we have not only excellent science that's being funded, but there is a lot of integrity in that process also. And like I said, we're, an NCI funding source. Again, they reviewed all of our process to make sure there was no behind the scenes. But it also is important in terms of being able to raise other money for the companies, for the grants that we're giving to the academic institutions. They have confidence and faith that what Texas is funding is driven solely by what is going to be the best for the patient and best for science. Another thing that I would say is, be thinking about the entire continuum. It is easy to, like I said, focus on basic research, discovery research, or, focus on, the star performers. I mean, I'm sure everyone in this room knows, okay, these people are absolutely going to get grants. Sort of like, we knew, of course, MD Anderson was going to be the powerhouse when it came to competing for CPRIT grants. They were already, superstars when it came to research. But, there were so many surprises for us, and in fact, one of our board members, early board members, was a former chancellor from Rice. And he was on that board because no one thought Rice would be receiving a CPRIT grant. They're not part of a medical institution. And that very first round of awards that we made, I had the unenviable task of telling the former Rice chancellor that he needed to resign, because it would be a conflict of interest now, since his institution would be receiving money from us. From the very beginning, places like Rice, UT Austin, before there was a medical school, surprising places were competing because they were coming at the cancer question from different perspectives. They were coming at it from an engineering perspective. Now it's easy to say computational biology and massive machine learning, but those were some of the early forerunners. They were looking at the issue differently, and so that's something to really keep an open mind and that whole continuum. And then also, we have certainly benefited. All of our money goes to grants for research or for prevention. We don't fund things like all of the groups around that support the collaboration. Places like TMC, where you all come together and meet and talk about the research that you're doing and the work that you're doing. And that has been, an incredible accelerant for what CPRIT has done. So I think I'm at the my amount of time. And like I said, I know that I'm just the opening act, and I really want you to hear the great things that are going to be happening in terms of neuroscience. But I'm here, for the rest of the afternoon, and I'm always reachable through CPRIT, so feel free to talk with me, and I'm excited for what this means for Texas. I think you've all heard, a potential $3 billion for, I've heard the Dementia Research Institute or Neuroscience Institute, but I mean, it really, in this day and age when we can hardly agree on anything, $9 billion invested by Texas into some of the biggest health issues that are confronting us today is quite an achievement and an accomplishment. So I'm excited. Thank you very much. I forgot, I am supposed to introduce Sarah Hine. Sarah Hine is the CEO of March Bioscience, and like I said earlier, March Bioscience is a CPRIT-funded company. It was surprising to me, I was talking with Sarah about this just before. We awarded them a grant. You'll know how much it was. A multi-million-dollar grant last year, and I was saying to Sarah, I can't believe it was just last year. I feel like I've known you forever. But part of it is I have known her for a long time because, and you'll hear about the pipeline of the development of, the research that then was, translated with the help of an accelerator into the company now that she runs. So welcome, Sarah.
Hello. All right. Well, thank you all for having me here today. I was asked to come in and just give at least a few thoughts on how a program like CPRIT, in this case, hopefully for neuro, but how a program like CPRIT can help drive commercialization, and particularly how can it help drive commercialization here in Texas, because I think that is what we're doing with our taxpayer dollars when we support a program like this, right? And I sat down and I was thinking about, what could that story look like? And I actually realized that I've been in Texas since 2010, and CPRIT has been a presence in my life and a sort of keystone of my own trajectory throughout that whole time. And so I originally came down here to get my training at Baylor College of Medicine, and during that PhD, I was luckily supported by a training award that a faculty member had applied to CPRIT for, and that was able to offset some of my stipend. I then subsequently left Baylor, worked with Mercury Fund to launch a company called Courier. We did not get CPRIT funding, but nobody's ever perfect all the time. There's no perfect system out there in the world. But we did end up selling that company. And then about the time that we sold that company, I went over to TMC Innovation to help launch this crazy idea, this new CPRIT-supported accelerator. They had done accelerators for a number of years, primarily in digital health and med tech, and those were typically more mature companies, and that's not what we're working with typically here on the biotech side. And how can we take some of those lessons learned, the infrastructure that TMC can bring to bear, and the lessons learned from startups, and launch a new program to find really cool innovation that had been being funded now for a number of years, both by the NCI and by CPRIT. You heard several $1 billion, I think, at that point, and help drive those out of the academic institutions and into companies. And it was through that I met Drs. Max Momokin and then Malcolm Brenner, and we were able to go from myself and two brilliant scientists and some really cool clinical data that I'll share with you really briefly out, and now we have an incredible company that we're driving forward. We're about to launch our phase 2 trial, and as Kristen mentioned, we did get a CPRIT award. We're about a year in. It was a $13.4 million award. I never forget. Exactly how much it was. And not that anybody's counting, but I think we were also the best score for our cycle, but So March Bio. So what are we doing here? And I'm not going to spend a ton of time on exactly what our product is, but I do think it's worth talking about it to contextualize both the impact the products that are being generated here in Texas can have, as well as to talk about why sometimes this isn't enough to get us all the way over the line and why we need these additional tools. So T-cell lymphoma is a smaller subset of the larger lymphoma and leukemia patient populations. But unfortunately, you know, your B-cell malignancies, that's the majority of your lymphomas and leukemias, they have a number of therapies available for them, everything from chemo to transplants, targeted therapies, immunotherapies, and now these things that we call cellular therapies. And that's where you take your immune cells out of your body, you engineer them, supercharge them against specific targets, and then you reinfuse them. And you can harness your own immune system with a little bit of engineering and drive curative, durable responses. We have patients now that have received cell therapies as children who've gone to college and are living their entire lives when otherwise they would have unfortunately succumbed to these very serious diseases. But this is not the case for these T-cell lymphoma patients. Even in 2024, the patients at diagnosis have about 30 to 60% optimistically overall survival at 5 years. And once they become relapsed or refractory, and unfortunately the very vast majority will, that drops to 10 to 20% survival over just 3 years. And so our CAR T-cell therapy that was developed by Max is able to target a target called CD5 and overcome some of the challenges that have held back the development and application of this powerful technology. I'm not going to get into that science, but what I am going to point out to you is a scan on the left here where you can see a patient who had a very heavy tumor burden and was able to achieve a complete remission just 4 weeks later. This trial's been ongoing at Baylor College of Medicine. 2 of the 4 patients that achieved a complete response are still alive now 5 years later. And then there's been improvements in the manufacturing. So the initial response rates were already beating standard of care, is about a 44% response rate. There's some improvements in manufacturing where it looks like we're clocking about a 60% complete response rate right now. And that's what we're taking forward into that phase 2 trial. So we're really excited because that would be an order of magnitude better than anything that's available to these patients today. And so it should be obvious, right? Clinical data, everybody says, go get clinical data. And then people will see that this is a compelling story and they'll throw money at you or Novartis will come buy your technology and you'll be done. And you know, especially if you have a high patient need. But the truth is that's not everything you need to do because there's still so much work that has to get done between that early academic data to approval. And then you have to navigate that, and you have to be able to tell that story. You have to convince people to put a pretty substantial amount of money forward to help drive that development and make them believe that you can get it all the way over the finish line. And so, obviously, the other sort of point to my favor, and I think really a true testament to my leadership, is we started March Bio during the worst biotech downturn in a decade. So timing is everything, and my timing of the market is poor, so you should use that as an indicator of where not to put your stock money in the future. But, you know, we felt like we had a really compelling story and we could put together the resources here in Texas. And so we forged ahead anyway. Just to sort of reemphasize that point, cell therapy is that third bar down, and you can see it's dwarfed by the investments into your more traditional drug classes, which are your small molecules and your biologics. And so certainly, whatever we did, if we believed in this product and we wanted to be successful, we had to be really strategic about how we were going to put the company together and how we were going to get those resources to help us drive forward. And so how to overcome what I should have put as nearly insurmountable odds, right? And so I call it sort of the startup boot sequence. The first step is you have to figure out what is the but-for question. Why has this therapy where we could see already that there was the potential, it's never done until you're not, but there's certainly the potential to create an order of magnitude improvement in patient benefits and drive complete responses not being picked up by pharma already. They have the pipelines, they have the capability, they have teams of really well-paid professionals. What were the risks that they were concerned about, and how do we start to navigate those? The second, and then you can work backwards from that. You can start to put together a plan. Sometimes in order to figure out what those but-for questions are, you have to go find the right talent. And that was actually something where here in Houston, we do have a fair amount of expertise in cell therapy, and certainly a network that is capable of reaching out even beyond our own borders to find people who can help to answer these questions and create that credible plan to help go get that funding. But really important here, and this is something where CPRIT and programs like CPRIT can really help catalyze a difference, which is you have to find that early champion. And at the end of the day, it's not just somebody who's, cheering you on, but someone who's going to be there with you and put real capital behind you to help you get through the earlier risk points to get enough momentum going to be successful. And then we've really leaned into a partnership model to supplement our weaknesses. Usually if you start a company, you're probably really good at one or two things. And you're probably not nearly as good at a lot of the other components of building a company. And so figuring out where your gaps are and then understanding how can you find people who are the best at those other things and work with them to be successful. And that's certainly something worth a lot of consideration. So when we were trying to beat this bare biotech market, we started in the ACT Accelerator. That gave us the latitude and time to build out that really early story. The resources and advisors through that program certainly helped us understand what those key gaps were as we were putting together the initial story. We took on our first seed funding from TMC and Portal Innovations. And that was really critical to giving us that little bit of capital to start to move forward. CTMC, we formed a partnership with them. They're our manufacturer. And they're themselves a CPRIT awardee. And so you can start to see CPRIT has funded multiple components of this ecosystem right now that even before we'd even gotten hardly out the door, we've already interacted with this program 2 or 3 times. We formed a partnership. We got investment from Cancer Focus Fund that allowed us to look at MD Anderson as our primary site to launch this trial. And we put that whole story together with that little bit of momentum that we were getting and how we were putting these pieces together. And we went to CPRIT and went through their process. And it's not easy. It's a rigorous process. I think Kristen was talking about that. You put together a very long application, both on how is this going to work from a scientific perspective, from a clinical perspective, what does your product development look like, all the way through commercialization. And then also, what does that commercialization story look like? Is it a product that can support itself, right? And we're really fortunate to get that award at the end of it. And all that momentum together is what really helped us close this Series A just a couple months ago. And so now we're launching a phase 2 trial, and we're launching it here in Texas. Our flagship sites are going to be Baylor College of Medicine and MD Anderson. But we're not stopping there because we're looking beyond our borders and we're trying to make sure we can get to the patients all over. And so that capital that we've put to the company has let us go out and envision a really robust multi-site trial. And one of the things that I would say is just really gratifying for me as part of this story is going out and finding all these clinicians and getting their enthusiasm was one of the easiest parts of this whole process. There's always a lot of hard parts of doing a startup, but talking to clinicians who had actually already heard about the Baylor trial and discussing with them about whether they would like to participate as a site for this trial is really fortunate. So we actually pared down from our initial list, which was a little bit longer even than this. And then this is something else I want to say, because I think sometimes when we think about these initiatives, there's this narrative that gets wrapped up as if it's a charity story, right? Oh, we got to just do, cancer, or we have to do, we have to go after these, neural diseases because, they're bad, and they are bad. But at the end of the day, you still, in order for it to be a viable drug, at the end of the day, it still has to be something that is economically supportable. And T-cell lymphoma is a really supportable market. And so our hope is when we get through all the way to the end and get to an approval, we'll be going in as a first and best in class drug, and we'll be returning money back to the state of Texas, right? And that's the goal here too. And they'll be able to turn around and go fund new companies. I might be one of them, so we'll come back and we'll come talk to them again. But that's the goal here, and that when we get that virtuous cycle going and keep that flywheel moving, that's what's going to let us keep doing this, not for just 10 years or 15 years, but for many, many years to come. And so we're building our pipeline. The March story is sort of just beginning, not ending. There's things that are here on the slide today as we think about where can we go from here and the places that we already have expertise in, and there's things that are not on this slide today that we're already working on upstairs, actually, in the portal space. And so really excited for the opportunity to keep telling the story and come back and keep everybody updated on how we're going to keep building, going after new and difficult indications and targets with great engineering and great biology. But it's not really just about us here today, right? It's not about should we fund cancer or should we fund these neural diseases? How do we build this ecosystem so we can keep going after these really difficult healthcare problems and create drugs that drive impact and build an ecosystem that is vibrant and profitable so that way we can all continue to make this the best hub in the world for life sciences development. So we're here today because of the CPRIT program, but really the larger point of the story is that smart capital at the right time really can catalyze growth. I do not think that we'd be able to have what looks like a really nice story without that CPRIT component in there. And so, my bias is always towards cancer. It's been my training now for 14 years, but it's not the only high impact disease. And I'll actually say when I was at TMC and we were running the Accelerator for Cancer Therapeutics, we would get these projects that weren't cancer, but they were good biology and they were products that had an opportunity to drive real impact for patients. And having these expanded views of how do we develop new programs to go after other really difficult healthcare problems, I think is a tremendous opportunity for all of us. So thank you all.
All right, hi everyone, I'm Kelly Jameson. I'm part of the strategy and new ventures team here at TMC. Super excited to see everyone here today, though I have a background in neuroscience, so I'm a little bit biased. It's my pleasure to introduce our next speaker, Dr. Amy Cruz. She's the Chief Investment Officer at Satori Neuro, which is a stage-agnostic fund focused on mental health, neurotechnology, and human flourishing in general. So she earned her PhD in neuroscience from the University of Illinois, Urbana-Champaign, and has since then served as a government civilian program manager at DARPA, where she created and oversaw the agency's first performance-oriented neuroscience programs. Additionally, prior to leading Satori Neuro, she was a general partner at Prime Movers Lab, served as the chief scientific officer of Optios, served as the vice president and chief technology officer of Qubit Global Defense. So today, Amy leverages her decades of experience as a neuroscientist, her prior roles as an operator and government program manager, and her network of key relationships to discover transformational companies addressing the largest mental health, particularly brain health, wellness challenges, and opportunities. So we're very excited to hear from her today. Please join me in welcoming Dr. Amy Cruz.
Thank you. Makes it sound like I can't hold down a job, but it's not true. No, it really is my pleasure to be here today and actually, to have the event kicked off by the work that CPRIT has done is truly inspirational. As someone who's been in the neuroscience field for decades, and really has been someone who has tried to create the industry as you have to create it as you go. It's been truly inspiring to hear the story of that, and I really hope that we're on a journey towards that in the neural sciences right now. You heard a little bit about my background. I was very lucky to start my career at DARPA as a program manager, and I like to say that it gave me that little thumbprint on my personality to really go after big, hard challenges, and I think that that is something that I've now carried into venture investing. And what I'm going to do today is really do two things. One is I'm going to sort of set the stage of what I call like, why now? Because a lot of people sort of ask me, oh, the brain, it's really hard. We can't figure, oh, it's so confused. It's like, no, actually, we have plenty of science, we have plenty of clinical insights, and I'm going to tell you why now is the time. And then I'm going to, maybe poke you a little bit and, offer a couple of ideas around the future. Because I think what we're talking about today is not just what's possible at this very moment, but if you lean in and really create a program that invests in research and companies and commercialization, we're going to create the future. We get to pick, and so I'm going to give you my 5-year, 10-year plus visions for a couple of different things, and hopefully poke you a little bit around that. So one of my little things is missing. That's okay. So why now? So the first thing is missing up there. It's called from synapses to systems thinking. So when I was a program manager, when I was a graduate student, very much thinking about the brain from the bottom up, and I think we now have the opportunity to think about the brain from a systems level perspective. Neurotech catches up with Moore's law. I'll give you some insights from what's happening in brain-computer interfaces and how that's sort of speeding things up with the technologies that we have, and then talk about what I call all roads lead to neuroplasticity, which is another enabling capability that I think is really happening right now. So from synapses to systems thinking, like I mentioned, when I was in graduate school, very much, neurobiology itself came from cell biology, right? It was a very bottom-up approach to thinking about the brain. And particularly over the last, I would say, 10 years, specifically the last 5 years, we've really started to understand the brain from a network perspective, from a systems perspective. We've started to think about diseases that we thought were quite homogeneous or actually just kind of lump them all together, and now we're starting to understand that they have a lot of heterogeneity in them. This, by the way, is one of the reasons that pharma and other groups like that got out of neuroscience, 10, 20 years ago, is because things wash out when we start to go to phase 3 and you up the numbers of, individuals and patients that are enrolled in trials. Well, that's because we didn't know how heterogeneous those diseases were, right? So depression, anxiety. Now we actually have the tools, both imaging, other molecular tools, genetics, to, help us actually kind of sort these biotypes and populations into ways that we can actually start to think about them, not just as depression, sort of mono, one kind of thing, but actually breaking that down into disease types. And so this has been very successful. We've actually seen companies now go back and rescue molecules that pharma had actually abandoned. So Eli Lilly tosses a molecule that, failed phase 3. Companies right now are going back, repurposing those molecules and actually doing this type of phenotyping and biotyping and showing that those molecules are successful. And so I think this is just one piece of evidence that suggests to us that there's a lot to be had in terms of thinking about the brain from a systems level perspective rather than just from a individual neurotransmitter or cell type. The second piece that I say is, neurotech has finally caught up with Moore's law. So the amazing compute that we all have in our pockets, right, our cell phones and everything else, a lot of that impact of neurotechnology didn't really happen right away, right? So a lot of times you saw systems that really remained in the lab, right? So they looked big, they looked clunky, they had, cables coming out and everything else, and everybody's like, oh, those are never going to actually turn into medical devices that will be deployed. Well, again, over the last 10 years, particularly over the last 3 to 5 years, we've seen the adaptation of these technologies really starting to use microelectronics in a way that allows these devices to be implanted, to be flush with the skull, to have either batteries that last a really long time or can be recharged. So we're really starting to see neuroengineering really starting to take advantage of what's been happening, with what's going on in microelectronics. And so there's a whole, I'll talk about, sort of what's happening in brain-computer interfaces in a minute, but just want you to think about the miniaturization that's happened in electronics and how that now is starting to impact the implantation of devices in the brain and body. So I like to say, my background when I was in graduate school was in learning and memory, so I'm a big neuroplasticity fan. But I like to say that all roads lead to neuroplasticity. One of the reasons that we've been able to develop and see the incredible results that we've been seeing, particularly in psychiatry, but not just limited to psychiatry, is because we now have tools to actually modulate these networks in the brain that I was just talking about, right? So we're using electricity, we're using magnetic stimulation, we're using low-intensity focused ultrasound to actually start to hit these particular nodes in these networks and drive and induce neuroplasticity in the overall sort of brain system. Again, you think I must have gone to graduate school 100 years ago, but it's not true. But when I was in graduate school, it was adult neuroplasticity was still sort of like, I don't know, maybe, and now we have such an observation that, one of the magical things about humans is that we retain the ability to learn and the ability to, have neuroplasticity in our systems well into adulthood. So this is one area, non-invasive neurostimulation, that I think is very exciting in terms of neuroplasticity. The second is something that you've probably heard about, might or might not be familiar with the number of molecules that are out there, but what's happening in the psychedelic medicine sort of ecosystem. This includes not only the first molecules, the traditional molecules, as I call them, the LSDs, the psilocybin, MDMA, ibogaine, other things, but we are now starting to see this second and third wave of companies working on new molecules that target the neuroplastogenic effects of these systems, of these molecules, while taking some of the hallucinogenic or trip elements out. So there's still a debate within, sort of the larger ecosystem as to whether the hallucinogenic or trip is required for the neuroplastic effects, but certainly we are going to actually understand if these things, can be used in this way, which would allow them to maybe be used as maintenance medications, maybe be allowed to be used as medications that could be combined with some of the other things that I sort of told you about. So those are some of the things that I'm excited about, right? So this systems level thinking in the brain, the idea that we're actually starting to be able to use some of these tools where we can actually implant them in the brain, leave them in the brain for long periods of time, actually have them impact, cognition and motor and sensory, as well as sort of the neuroplastic effects in general. So here's how I look at kind of the innovation ecosystem. This is Amy's view, right? And so when I started investing, initially with a broad deep tech fund. So I joined a fund that was quite broad. They did space, energy, agriculture, nuclear fusion, and human augmentation, right? And so started investing in kind of all things neuroscience, implanted brain-computer interfaces, non-invasive brain-computer interfaces, mental health, neurostimulation, longevity, diseases of aging, right? And so really kind of started to get into what we call the deal flow, right? Started to see the companies that were out there. I was then recruited to join Satori Capital. Satori is headquartered in Dallas-Fort Worth, which is where the fund is also headquartered. They were a broad started out as a private equity group with a conscious capitalism ethos. And then over the last, so that they started about 15 years ago, over the last 10 years have sort of built alternatives offerings on the platform, had a real passion, the partners there had a real passion for brain health and mental health. And so recruited me to join up and run the new fund, which is called Satori Neuro. And at Satori Neuro, we're focused on mental health, brain health, application of neuroscience technologies, as I mentioned before, human flourishing. I like to think that we will not only, someday be able to work on the clinical challenges that are ahead of us, but really enable capabilities and flourishing for other people. But anytime we start a fund, you kind of have a thesis, right? So what is your approach to the landscape? What is your approach to the world? And sort of, because I'm a scientist, I had a hypothesis that there would probably be about 4 things that would be really critical to look at in this space. So therapeutics, which you've talked about, but I would say therapeutics like a little bit funky, right? So the things I've talked about in terms of psychedelic medicine and those adjacencies, the impact of the microbiome on the gut-brain axis. So think about different ways of approaching therapeutics for the brain and the nervous system. Hardware and devices, of course, that's one of my most favorite things. So you'll see me looking at non-invasive neurostimulation, minimally invasive devices, even things that are, could be potentially consumer-facing, light, sound, other forms of energy to modulate the nervous system. Really excited about diagnostics and precision measurement, right? So one of the things that we talked about in the, systems approach to things is actually starting to develop quantitative measures for mental health and other challenges, right? So many of our endpoints and our data points in this world are qualitative. Those are important. But all the things that I just told you about how we can measure the brain and how we can understand the networks in the brain, those types of things are not yet standard tools for understanding not only the development of disease, but also, if a particular treatment is therapeutic and has efficacy. And so this is a really important area. What's happening is pharma is starting to get really interested in this, of course, for the reason that I told you before. It turns out these things are quite heterogeneous, and so using quantitative measures is really allowing them to sort of go back and do better phase 2 trials, do better phase 3 trials, but eventually those things will also become diagnostic in nature, and hopefully one of my goals is to be able to front load some of these measurements so that we can get people into the right treatment the first time. And then the fourth piece, which is something that I was sort of new to me but really instinctually felt really important, was the idea of infrastructure and access to care. So, okay, I've created all the best, our companies have created all the best therapies in the world. How are people going to access them? How are they going to pay for them? How are they going to navigate to that particular care? There's peer support, there's telehealth, teletherapy, novel insurance mechanisms to pay for these, emerging things. And so from my perspective, like I said, mental health is sort of the pointy end of the spear in terms of the things that we're focusing on right now. But neurodegeneration, cognition, even performance, all of these things are intimately tied together because it's the brain, right? And it's actually been one of the biggest challenges, I would say, as an investor in this space. Very often, solutions in the neuroscience space are treated, I would say, a little bit classically, right? Like med tech, kind of things. And I was like, no, a pacemaker is a pacemaker, but a brain-computer interface that can actually interface with multiple parts of the cortex and decode and put information into the brain is quite a different device than something that's just really specific in that regard. And so that's one of the things that I'm most excited about as we start, building investment in this space, is really embracing and understanding the platform potential of what's happening in neuroscience and neurotechnology. My colleague, Dr. Harris-Eyre, will be talking later about sort of the brain economy, so I won't belabor the numbers too much, but I think it's probably, kind of goes without saying that this is a massive, massive investment area. As we've all talked about, these are important things. We all want to, we all want to see cures and preventative measures get out there, and at the same time, we acknowledge that these are businesses and, need to survive. But I think the evidence is quite, overwhelming for the impact of brain health and brain health technologies on the economy, and also, in terms of, the outcome of those treatments themselves. So I won't belabor that. I wanted to just give you a little snapshot of some of the things that I'm seeing as I look and talk to, hundreds of companies in this space. Some of the things, on this list are the things that I've already mentioned, brain-computer interfaces, bioelectronic medicine. A lot is really interesting and happening in the space of advanced brain imaging and the connectome. So if you think about, the stuff you see on, I always call it, stuff you see on CNN, you see the little blobs light up, I call that blobology, right? The connectome is actually the connections that make those networks that I was talking about, right? Individual regions of brain aren't particularly interesting in and of themselves until you actually think about the ways that they communicate with one another and what that means from a network perspective. Starting to see a lot of really interesting, sort of developments there. Talked about mental health, novel molecules, obviously what's happening in neurodegeneration. Some really interesting things if you think about kind of like drug and pharmacology in general. One of the things that's challenging about drugs is that, even if you want it to get into the brain, it doesn't necessarily just target the areas that you're interested in. And so there are companies right now working on actually caging molecules, so putting a little, imagine a little cage around it, sending it into the brain, getting across the blood-brain barrier, and then using focal stimulation to actually release that drug at just the specific area that you're interested in. So imagine, releasing a drug just at the hippocampus or just in the substantia nigra or something like that. I talked about precision psychiatry. I'm really, really, really excited about sleep augmentation. I will have a follow-up slide about this, but obviously from my work originally in the military and working in the DoD, a lot of interest in sleep modulation, and I think I'll make a comment around where I think that impacts us as a lifestyle factor. Talked about the gut-brain interaction. Of course, wouldn't be a talk without saying AI. And so, starting to see people taking a look at creating foundational models in the brain. There is a lot of brain data out there. The neuroscience community in general is not one that has typically shared data sets and has a lot of, kind of shared information that you might have seen in like the computer vision world or other places like that. And I think that's starting to change. There are a couple of data sets that people are starting to operate on, and I think there will be more. And of course, what's happening with virtual reality and augmented reality. So I'm going to give 4 bold predictions. And again, these are meant to be, of course, we'd all be bajillionaires if all of our predictions came true, but it's really meant to be illustrative and sort of spark ideas right around this. So, my idea, I think we all know, or maybe you catch up here and figure out what's going on in brain-computer interfaces. The clinical work is pretty much done. Like, we can decode speech, thought in real time and turn that into text. That has been demonstrated by Eddie Chang and others, UCSF, the work that's happening at Stanford. We know how to do that. The question is, we actually need to turn those into devices that can be implanted in people's brains for long periods of time, like 10 years or more. And so we're right now, within the next 5 years, on the path to having those devices FDA approved. They will hopefully be prescribed and reimbursed, which will, help make that quite successful. But in the short term, it will be for the restoration of function, right? It'll be for people with ALS, it'll be for people with stroke or other motor disorders. And then I do think that, BCIs or brain-computer interfaces will be used in some fashion that we would call closed loop, right? So not just decoding information out of the brain, but potentially putting information into the brain or using electrical stimulation to enhance those systems. I think, it's perfectly reasonable within 10 years to think that, implanted BCIs will be first-line treatment for the treatment of ALS. I understand there are people working on molecules and sort of pursuing that path. They haven't yet been successful, so I do think ALS and things like that will be with us for quite some time. Based on the work that I'm seeing from my colleagues, and of course there's now new venture funds that are out there to work on spinal cord injury, I think we're gonna bridge the gap. I think people that have severed spinal cords or other types of spinal cord injury will essentially be able to repair those, if not with stem cells, at least with some sort of electrical bridge. And then, just to be a little spicy, probably within 10 years, somebody will, decide to do an off-label use of brain-computer interfaces, whether that's for enhancement of sensory function, whether that's something else, cool app that somebody has created. But I really see that as, the outlier case, even within the next 10 years, based on the technologies that I'm seeing. I could be incredibly wrong, of course. Sleep augmentation, so, throwing out some ideas there. I'm a biohacker myself, so I'm wearing multiple tracking systems right now. I've got my Oura Ring. I've been experimenting with another one, Apple Watch, other things like that. You probably saw, or maybe you heard about Dexcom, so the maker of CGMs, right? Continuous glucose monitor just made a $75 million investment into Oura, which is one of the ring-based trackers. I think we're getting to a world where, we've obviously turned over a lot of real estate to devices, and I think we're going to continue to track our sleep, through those types of things. But right now, from a clinical perspective, EEG is still the, gold standard for tracking sleep. And so I think, that remains, as it is right now. And right now, in terms of interventions for sleep, cognitive behavioral therapy is still the gold standard. In 5 years, I absolutely think we're going to have, pretty crazy AI-enabled tracking of our sleep whether that's going to be embedded in your earbuds, whether that's going to be embedded in your mattress, I'm not entirely sure. But I'm already seeing companies that are showing closed loop augmentation of sleep. So there's both electrical stimulation that can be applied while you're sleeping to either enhance slow wave or REM sleep. You can also use sound. You can use a variety of different things. I think that's going to absolutely be well within hand in 5 years. Some of the neurostimulation treatments I talked about, will probably be the frontline treatment for insomnia or shift work disorder, because we can go deeper into the brain with things like low intensity focused ultrasound. I think we can actually start to modulate some of those deeper structures in the brain. And then there's this really interesting thing that I think is going to happen if we actually start to pay attention to the lifestyle factors that are related to dementia, neurodegenerative disease, and other things like that. Sleep is an enormous risk factor there. And so the quality of sleep, you may have heard of the glymphatic system, essentially this sort of, I'll call it wringing out the sponge of the brain, getting the gunk out of the brain. Slow wave, that happens during slow wave sleep. We should be able to enhance that in and of itself. And then I think probably within 10 years, I think you're going to be able to program your sleep. I think you're going to decide tomorrow I need to be super focused. I want lots of REM sleep and something else. Maybe I need some recovery. You're going to sort of dial that in. So I actually think we're going to get there. We're going to do power naps for sure. I mean, I already have a couple of companies in the portfolio that are working on giving people really short restful bouts of sleep, so you're not going to maybe even need to sleep a whole night, or if you're going to need a refresh, you can do that. I don't think insomnia is going to be treated with pharmaceuticals for much longer. And then, bold claim, I think if people actually, start to pay attention to sleep and prioritize it, I think we'll start to see a decrease in neurodegenerative conditions. Last two to sort of go, precision psychiatry, I've talked about this a lot. Biomarkers, we've talked about those. We have the biomarkers. I think the data is out there for what we need to do. The question is, can we pull this into the future, into actually using these devices and these measurements on an ongoing basis? And so I really do think that the same way that my Apple Watch checks in with me, asks me if I want to stand, asks me if I want more steps, or, change my goal for the day. I think we're going to start to see that, from a mental health perspective and even a psychiatry perspective, this overall monitoring. It's very clear that we can use the passive devices that we have on our bodies and very simple interactions with systems to, at least at a very top level, classify where people are doing from a mental health perspective. I think one of the things we need to do is supplant, these qualitative measures with much more quantitative measures. I think that's happening. I really, really think that we're going to get to a point where diagnostic screening for mental health conditions in particular is so specific that people will actually get into the right treatment the first time, as opposed to experimenting on them, which we do now. Try this one, try this one, try this one. Treatment-resistant depression is someone who has failed 3 or 4 frontline treatments with no relief. Do you know how long that takes? For some people, it takes 3 years, 4 years, for some people 10 years to actually find a solution for them for treatment-resistant depression. We can do better, and we're going to do better. In 10 years, I think we will have routine screening for mental health, which includes the screening of children. So you may or may not know, right, children born of parents that have some type of mental health challenge or disorder are, upwards of 50% likely to develop a mental health challenge themselves. I think we are on the cusp, after COVID, of a real mental health crisis in our youth, and I think we, haven't really seen the biggest cresting of that wave, and I think screening for, for kids is going to be critical. I think mental health, and I think we're already on this pathway, thankfully, but I think it will be treated without stigma. And then I think we're going to get to a place, so I've talked about diagnostics, I've talked about these things, but I do think that once we have these types of measures on board and actually working, I think we will be able to predict serious mental health issues and episodes in individuals and relapse. I actually think we're going to really get there so that we can prevent people sliding down into really serious mental health, sort of conditions. And then finally, I'll just leave you with, kind of where I think we're headed with neurodegenerative disorders. I think there's been a lot of activity in this space. I think the beta amyloid hypothesis that we, started 20 years ago, I think we've really, started to understand that that's probably not the whole story. Mild cognitive impairment is still really hard to diagnose and know, kind of when to intervene and when people should intervene. We're starting to see blood-based biomarkers, PET, positron emission tomography biomarkers, stuff that's in the cerebrospinal fluid. We are definitely getting there. Through the Michael J. Fox Foundation, through the Alzheimer's Discovery Foundation and the moonshot around that, I think we've seen some incredible thing. This is something that always kind of blows my socks off. 40%, right now, they are estimating that 40% of sort of neurodegeneration dementia can be prevented by changes in lifestyle factors. I think that's incredible. But what do you do about it, right? And so I think we're starting to get into the space where we can actually start to put some structure around what those lifestyle factors are. I've talked about sleep, exercise. What we're seeing right now with cardiometabolic and the outcomes that people are seeing with GLP-1s and the impact on the brain, there's something there. There's something around, the interaction between the brain, the body, glucose. I mean, your brain is the biggest user of glucose, right, in your system. And so I think there's something there. I don't know what it is. There's a neuroinflammation, hypothesis that's also playing around. So I do think we're going to get to a space where we have, quantitative biomarkers. I do think we're going to get to a place where, from a mild cognitive impairment perspective, we can start to intervene. We know that cognitive exercises and cognitive training are efficacious. Nobody wants to do them. So, I mean, I as somebody who actually tried to sell, cognitive training and those types of things, like, they do work, but I really think that where we're headed with neurostimulation and actually putting energy and putting, that kind of stimulation into the brain is much easier to think about, someone with mild cognitive impairment doing. And then I think we're going to get to a place where, we can actually reduce the progression of these diseases through the interventions, the lifestyle interventions, through what's happening in neurostimulation. Obviously, they're still working on pharmaceutical pieces. I think we're going to move neurostimulation in general closer to patients. And so I do think we're going to see decreases. We're probably going to go through a peak. Obviously, we're reaching an aging window here, not only for our society but for others. But I think it's one of the reasons that I think we should spend time and energy and work in these spaces. So anyway, these are just some bold predictions that I have and wanted to share with you today. They're meant to be thought-provoking. I'm not right. I'm not intending to, sort of be right. But in terms of what I see and the companies that I see and the other things that are out there in the innovation landscape, the work is there. And I think, part of the conversation here is around the investment and the funding. I'm one investment fund working away. We need, probably a lot more capital in this space to really make these things come true, but that's what I'm working towards. I appreciate it. Thanks for your time today.
Thank you, Amy. It's great to sort of see what the future can be. And for two of the areas that you spoke about, mental health with depression, PTSD, as well as neurodegenerative is going to be what our two panels are on after the break. So right now we have about a 15-minute break. We have some more food, drinks out, but really want to use this time to network and get to know everybody. So thank you very much. Hi, everyone. We are going to go ahead and get started with our first panel. As we heard, there has been so much movement within the mental health space, but there is still such a long way to go. So when you think of long-term depression, PTSD, trauma, and all of the impact that that can have. So I'm excited to introduce our panel of experts. These are all people working within the Texas Medical Center, focusing in on PTSD and trauma. So they're each going to introduce themselves. So I'm quickly going to have them come on stage, and we'll get the panel started.
Thank you. So today's topic is navigating trauma and PTSD, and I have three wonderful panelists here. And I'm going to let them introduce themselves because I cannot do justice because their CV, if you look at their CV, it's pretty long. And we have three wonderful panelists. So let's start with Dr. Israel Lieberson.
Thank you very much. Hello, everybody. I'm the distinguished professor at Texas A&M University. I came here about 7 years ago. Before that, a little bit less, 6.5. And before that, I spent 28 years on the faculty of University of Michigan. I was interested in trauma from the beginning. And I was studying neurobiology of trauma on different levels, cells, animal models, brain systems in humans, functional neuroimaging, treatment, and combining those things in designs like pharmacofMRI and so on. We published quite a bit in this area, and at some point we're brought in here to Texas A&M to help build the first department of psychiatry in Texas A&M, and here I am.
Next, we have Dr. Johanna Beck.
Hi, everybody. Thank you for inviting me. My name is Johanna Bick, and I'm an associate professor in the psychology department at the University of Houston. I've been here since 2016, and I'm trained as a clinical psychologist, but I did my postdoctoral training in developmental cognitive neuroscience. And for the past over 20 years, I've been studying the effects of early life stress related to parent maltreatment, to young children, and correlates of risk like poverty, and how it shapes development. We've known for decades that children exposed to extreme stress at vulnerable periods have a host of problems psychologically, cognitively, and even if you fast forward decades, they're at risk for health diseases. And I became really interested in understanding why that is, and grew into being fascinated by the use of neuroimaging to understand the mechanisms for how these experiences program the brain and help us understand trajectories of risk and resiliency. And so that is a focus of the lab that I direct at the University of Houston.
Thank you. And next, we have Dr. Jacob Robinson.
Well, hey, everybody. I'm Jacob Robinson. I'm a professor of electrical and computer engineering at Rice. I'm also a founder and CEO of a company that we spun out of the lab called Motif Neurotech. I came here about 11 years ago or so when I was hired by Benham Ajang, who is here today. Hello, Benham. And he was kind enough to offer me a faculty position here to build a neurotechnology lab inside of an electrical engineering department. At the time, I was this weird person who wanted to develop devices and interface them to the brain, and people are like, what department does that live in? And fortunately, Rice was forward-thinking enough to start a neuroengineering program. And over about a decade, we began developing devices to stimulate record brain activity. We were fortunate to get NIH funding and then a large DARPA award to develop brain-computer interfaces. That was about an $18 million award that we led here at Rice. That allowed us to de-risk a lot of the technology that we had been developing. And we took the technology to a point where we got really excited that we had solved some fundamental problems about building devices that might be able to interface to the brain. And at that point, I had a few conversations, including one with Amy Cruz, who talked about the importance of neurotechnology, and she convinced me that I should actually think about commercializing the technology. And about 2.5 years ago, we started that company because the data showed that there were some really deficiencies in the way that we were addressing mental health with the tools that we had available today. For example, we know that suicide is the #2 leading cause of death for people ages 10 to 34 in the United States. We also know that about 1/3 of people fail 2 or more medications. And so we have this incredible unmet need, and our ability to treat this disorder is severely limited. At the same time, we know that circuits, as Amy had talked about previously, are often the underlying mechanisms for these disorders. And so what we're building at Motif is the ability to modulate those circuits with minimally invasive devices. We closed Series A in January and raised about $20 million to begin a clinical trial here in Texas within the next 18 months.
Thank you. And a little bit about myself. My name is Asim Shah. I'm a psychiatrist by profession, and I work at Baylor College of Medicine. I'm a professor and executive vice chair at Baylor, and also the chief of psychiatry at Bentob and Harris Health. So usually people start with what we have, but I'm going to start with what we don't have. So let's start with what we don't have in the field of trauma and PTSD. So what are the major unmet needs for trauma and PTSD? And I'll start with you since you are sitting next to me.
Well, thank you for the topic, what we don't have.
It's a pretty loaded topic. So
Huh?
It's a pretty loaded topic,
Yes,
so you can go on and on, I'm
and
sure.
the decision for me is what is it the most critical thing that we don't have? And it's not very different from trauma and other mental health disorders. It's actually similar. And what we don't have is a precise understanding of the mechanisms. And that's the critical component. Now, why trauma unique? Because in trauma, we have a starting point. This is something that we don't have for other disorders. In trauma, we have a place to start. And this is one of the reasons why the neural systems that involved in trauma have been developed and learned about them. I would agree more than for any other psychiatric disorder in the last 20 years. Not because I was involved, sorry, I'm just kidding. But because we had a place to start. And we started with this place. And that's the most important thing. We already know the system that are critically involved. What we need to know is exact circuitry changes, and what we need to know is the early neurobiological markers of risk for this disorder. Because when we put our finger on that, we can unravel clearly the mechanism. And if we can unravel mechanism, we can develop treatment. So in my mind, the critical part is unraveling the mechanisms, is identify neurobiological predictors specifically for the risk, because we can wait and look on the trauma and see how it changes. So we are in a very good place there compared to, in my mind, to any other psychiatric disorder. And it's ripe to work. And as a matter of fact, we and others funded by NIH and NIMH and DOD and so on, we are doing those projects as we speak.
Dr. Bick?
Sure. I think that is a question that I could probably talk about for hours, but I think there are things that I feel what we don't know are missing on the clinical front, but also on the research front. So in the clinical front, I think we know that in my area, prenatal stress or having a parent with a mental health problem or being exposed to extreme stress increases risk, but our screening efforts in healthcare community settings are not to the level that they need to be, in that we are missing a lot of people who maybe don't get prenatal care appointments or can't access the screening services, or if we do screen them for prenatal stress or psychosocial risk that we know affects the developing brain, we may not have treatments to refer them to that everyone can access. So I would say building that area is an important future direction clinically. But also, I focus on an understudied area of the lifetime. So how these stressful experiences and traumatic experience from parents wire the brain and program the brain, even starting in birth. So my lab and other labs are showing that maternal histories of trauma can affect the structure of fetuses' brains in the third trimester. So understanding these really early origins of stress and trauma, how that programs development, and how we can use treatments to identify causal mechanisms and to support resiliency at these periods of brain development. They're most sensitive and the most vulnerable. And I think we are still at this level in the field where we understand these main effects, but we need to understand more about individual differences and then apply our neuroimaging insights to treatment.
So a slight change for you, because you have a company. So when you think about non-dilutive funding, how can that impact, or how did that impact creation of a company like yours? And did it impact in any way, or how do you see that impacting?
Yeah, I think this is a really important point. We were very fortunate that we had the kind of non-dilutive funding that we did in my lab. I mentioned that we had a DARPA award that was followed up by an ARPA-H award that allowed us to de-risk a lot of the fundamental technology. It also allowed us to get early clinical data. So Sarah presented her story at March Biosciences, where CPRIT was that non-dilutive funding source that bridged the gap between an idea and that first hint of clinical data. And that's the point at which a company becomes investable and can then leave the lab. We only were able to do that because we were fortunate to get that DARPA award and the NIH awards. Unfortunately, the BRAIN Initiative funding has been cut dramatically over the last year, about 40%, and so I worry that in the absence of those types of non-dilutive sources, it will be very difficult to translate some of the breakthroughs that we have here in Texas at the universities into the types of sustainable businesses that are ultimately going to impact the patients who are in need. So it's an incredibly important step in bridging that gap.
And Dr. Lieberson, does it affect any of the work you do, the non-dilutive funding?
So we do have projects in Texas A&M that originated in collaboration between Texas A&M and private entities. I'm sorry. Okay, apologize. I say we do have projects that have been in a collaboration between Texas A&M and the private entities, private companies that develop some kind of a device and so on. And we try to see, for example, does it work for trauma? We have a particular EEG signatures that we are interested in, which we think associated with trauma. This is one of those biomarkers that can be used. And this company has a specific device and specific treatment that based on that. I think it's a very important pilot data or beginning data to start demonstrating. And I'm looking forward to see the result of this trial to see if we can use that as one of those potential both treatment but also markers that we can start using to sort out what are the mechanisms, what are the problems within the trauma that will be sensitive to this type of intervention, sensitive to this. So one of the critical things in trauma, and I'm sure that Dr. Beek will agree with me, that while we have a good treatment, we have a medication treatment, we have psychological treatment, we're trying to do TMS, right? All of that. The problem is that bring me the patient, and I have 30 years experience, and ask me, should you start that or that or that? It's a toss. We don't know. And they will not respond to all three of those. They will probably respond to one or two. How to bridge that? Previous speaker were talking about 10 years chronic depression. The same thing is non-chronic trauma. We need to be able to identify biotypes and to do the biotypes. So I'm very much looking into this process where private funds, government funds, whatever we can do, will advance the process where we can take the trauma biotypes, trauma biomarkers, and use them for therapeutic approaches.
So you're talking about biotypes. So if you think about unmet needs, what would be the major unmet needs in Texas? Just focus on Texas. What would be the major unmet needs in Texas for you?
In Texas? Well, again, I think for me, for what is major, and I don't want to speak for everybody, but for me, the weakness is a focus. Texas is not focused enough. let me put it this way. Let me be honest with you guys. You go to Maryland, say, what's the neuroscience institutes? Everybody can tell you. Everybody can tell you what are the major institutions and what the neuroscience structure behind that. Go to California, well, Stanford. Go to Iowa, well, Iowa Brain Institute. Everybody has a leadership where they have a critical mass that gets together and enrich each other from the cellular level to fully functional level, and in my mind, including public health level, have to be included into this process. And we don't. We have everybody calls themselves institute or calls themselves something, but in reality, we do not have a critical mass to take next leap, next step. Because when I talk about biomarkers, it's many different levels to understanding that, probing that, neuroimaging, genetics, precision genetics, looking on response to treatment, looking on different levels. To do that, you need to have experts from multiple different arenas sitting in the same area, sitting together and discussing how to do that. And it's hard. It's hard to do it on the level of single institution. TMC has the opportunity to contribute to that because we have a lot of institutions and a lot of people who are interested here. We need to create a further structure that collaboration can be active.
Dr. Bix?
Yes, I'm glad you mentioned that. I 100% agree. I think that Houston, especially, and the Texas Medical Center are unmatched in terms of this diversity and the caliber of our medical centers, but it's the galvanization and the collaboration that seems missing. So for example, I was at a conference recently, and there are lots of initiatives for big data enterprises across the country that are funded by NIH. And we are a prime candidate to be participating in those, but because we are not known as a hub of neuroscience, we are often overlooked. And it's not because of our lack of potential, it's just because we are not yet on the map, and I'm dedicated to bringing us all together so that we can provide important data to represent this area of the country that isn't represented as well in big data initiatives. We have the technology, we certainly have the infrastructure. It's just really talking and working together and bringing it together in a more unified way, and I think that will attract funders and innovation. And I see that being a really critical direction for us going forward.
Also, would you like to talk a little bit about the challenges you have in terms of integration, when it comes to integration, whether it is integration with academics or any other integration?
Sure. So I run a research lab, and we couldn't do our work without collaborations with hospitals and community centers. The populations that we want to access require relationship building and trust, and it really does take scientists and interdisciplinary connections across all levels. So networking and opportunities like this are great to start talking about these ideas and reaching communities that probably aren't coming to the medical center, that can't get to the scanner. And that really biases the work that we're doing because we are really only at the tip of the iceberg in terms of understanding the effects of extreme trauma on the brain. So I think bringing technology to communities in new innovative ways might help, and also partnering with lots of different organizations to increase our access is really important.
Thank you. Dr. Jacobson, so in the past decade, things have changed a lot. Care has changed a lot, treatment has changed a lot. And when you think about innovative ideas and changes, of course, your company comes to mind. So tell us a little bit about what your company is doing in terms of mental health and new challenges and new changes, and how are you interfacing it with all these changes and challenges, and what are the new things on horizon?
Yeah, sure. So I alluded to it earlier, but the way that we're approaching mental health challenges is based on a lot of the breakthroughs that have happened in the last decade from fundamental neuroscience. I think Amy talked about it in her talk, but there's a recognition that we are approaching precision biomarkers. We may not have exactly nailed them down, but we have a wealth of data that we've never had in the past from wearables, as well as activity on people's mobile devices and computers. The other thing that has been really important is about a decade of really focused fundamental work in neuroscience to understand the circuit level nature of these disorders. So these are not, as Amy alluded to before, these are not monolithic disorders. When we say depression, it is not one disease. We've kind of known that for a while. We're now being able to pick out, based on physiological differences, what is the specific disorder that a person has. And I like the analogy here to cancer. It's, if someone has cancer, it's not like, oh, you have cancer, we have cancer drug, take cancer drug, it's going to work for you. It's like, no, I have like small cell lymphoma, right? We have these very narrow specific types, and if, oh, you have small cell lymphoma, we have a very specific drug for you to take. We're approaching that now. We have the ingredients to do that in mental health, where tests will allow us to say, okay, you have depression type 4, you need, maybe an SNRI, or actually, let's go straight to TMS, because we need to modulate the executive function network in order for you to change out of this state of obsessive rumination. And so, given the fact that we have now this mechanistic understanding, I think the next breakthrough is, do we have the technologies in order to do something about the fact that we can now specifically diagnose patients? And the answer is yes. And it's yes because we've invested in technologies like neuromodulation or brain-computer interfaces, or in some of these AI algorithms that can take very large data sets and give very specific answers about clustering and phenotyping. So in summary, this combination of a better fundamental understanding of the specifics of these mental health disorders, more precise ways to target those exact circuits or those phenotypes, then lay that groundwork for companies like ours. And so our approach is to say, okay, we can now take people who suffer from depression, understand that it is actually a subset of those people who lack executive function control. What do we do with them? We have a device that can be implanted in a 20-minute outpatient procedure. They go home that day, and we can stimulate the executive function network. They can recover from their depressive state, and they can stay in remission because we can continue to modulate that circuit and measure brain activity and provide stimulation as they need over time. So a pharmaceutical adjunct, because we have a fundamental circuit understanding of how brain disorders work, and we have technology thanks to things like Moore's Law that could be miniaturized and send people home that day.
Dr. Lieberman?
Yeah, I'm very appreciative, first of all, of you taking, because sometimes we who are involved in the field, we use our jargon, and lingo is important. I call it biotyping. And I thought, oh, everybody understands what biotyping is. You just get a pure explanation, and thank you so much for doing that, because this is exactly what it is. I mean, biotyping is identifying biological phenotype to whatever disorder that we have. And as you have correctly pointed out, depression probably, well, it still might remain depression. So it might be depression, but it could be subtyped. Is it a prefrontal depression? Is it reward nucleus accumbens system depression? Is it depression secondary to executive functional losses due to dementia? So there's so many specific. That's exactly what I was talking about, biotyping, understanding the mechanism. I also agree with you very much that I'm kind of mechanism kind of guy, which bone connects to which bone. Otherwise, I don't understand. And I think there's a lot of links between the bones are not clear. So yes, we do have a lot of signals here that we kind of identify. But a lot of that is not detailed enough. And for me, detailed is from cellular level, molecular level, cellular level, circuit level, functional level. All of that has to be filled before we can say biotype. Doesn't mean that we don't need to treat earlier. So I think that's a very important challenge to continue. Because think about it, 70% people respond to treatment. What does it mean? Well, it means that some people respond 100% for the treatment. For trauma, I can tell you in a study of 7 years that we have run, we got 15% or 20% people full recovery. Good. Recovery I'm talking about, not response. And then we had another 50% of the people response, meaningful clinical response, the way we define that. And then we had 25% that did not respond sufficiently. These are not same people. We need to understand, because very much important for us to understand how this person who respond 100% differs from people who responded only partially. Because maybe we need to add, maybe we can augment, maybe we can prevent in some people. So to us, understanding these processes and prevention, in effort for prevention is critical. So the biotypes are critical to try prevention. So we can slice this amorphic diagnostic system that we all use, but has kind of a vague boundaries, into more specific, mechanistically defined, treatment responsive subtypes of disorder, like in cancer.
Also, since we're talking about future, what do you think are the next frontiers for research? What would we be researching on in the next decade, you think? This is for you, Dr. Lieberson.
Well, I think everybody can predict my answer here. You heard me talking about it. And I'm submitting grants and other people submitting grants. But for example, I'll give you an example. We have, in trauma, to me, the predictors will be the biggest breakthrough. And I'll explain to you why. Wars are happening all the time. Children get hurt all the time. Unfortunately, wars are a little bit more predictable. We know before a person gets deployed. So we, together with a number of scientists all around the country, under Texas A&M leadership, created a small consortium with 7 or 8 leaders in different areas of neurobiology. And we are trying to put NIH, to get NIH and other together to put large study in Ukraine military. Right now they're recruiting 10 brigades. If we get enough information, biological and good clinical information with them, and we can follow that up for a year, within 2-3 years after that, after we finish the project, we can bring answer to those questions that I'm asking. And to me, that in trauma, that will be the breakthrough, because it's the fastest way. Because as I said, in trauma, unfortunate but lucky situation for us, we know when it starts. So we can start before that. We can prepare ourselves before that. We can start predictive studies, neurobiological predictive studies. This is the core questions that needs to be addressed, and we are in the process. So my bet, that will be the biggest breakthrough in the trauma. Now we're doing neuromodulation, we're doing, as I mentioned, things had to do with in treatment. To me, those are all important, because every person is important. But if you talk about the field as a whole, in my mind, this is my call.
So Dr. Bix, if you think, you want to add to that? Or, okay. So if you think about Texas, Texas is unique in many ways, and Texas has a lot more challenges than some other states. And funding always is a challenge. So what do you think makes Texas this unique, and how can we address these challenges, especially relating to funding in Texas?
Sure. Well, I think, as I commented before, Texas is, I think, the 4th largest state in the nation. One of the most. Houston is the minority-majority city, and we have all of the capacity that we need to innovate, and so I think those are our strengths. but also challenges for how we can collaborate and figure out ways to not just do the research, but really test the practical applications of our research. So for example, I study pregnant women and children up until 8 years of age. We will not do neuromodulation. We won't do PET scanning for ethical reasons. We do awake scans. We can't inject them with tracers for ethical reasons. There's no medical reason why. And so, scanning time, and it's very challenging to have a 2-year-old sit in a scanner for 20 minutes. And it's expensive. It takes a very skilled, specialized type of training. And it's possible, but I think realistically we need to think about using other devices like wearable technologies, delivering interventions remotely rather than having them come into the clinic, taking advantage of advancements in low-field scanners where we can bring a scanner out to communities rather than having them come into the medical center. And I think we won't get as good resolution, but what we'll gain is more data and representation. And the other thing that I think is really exciting in my field is that the combining technologies, moving toward multimodal collection. So all labs usually specialize in one technology, but really for us to understand the brain, how experience shapes the brain plasticity, the effectiveness in interventions, we need to understand structure and function and other biomarkers like autonomic nervous system, cortisol. And if we can collect all of this data together, we can create better predictive models for understanding those likely to respond to treatments, those likely to develop a form of psychopathology. And again, moving away from this kind of categorical model and really thinking of trauma as very heterogeneous and transdiagnostic and influenced by lots of different things. So the effect of poverty or not having what you need on the brain is very different than being reared in a threatening environment where your life is at stake, and understanding how the experiences program these systems, the reward systems, the frontal limbic systems, the cognitive control systems. We're not going to make much progress until we get more mechanistic about how the environment shapes the brain and these systems and influences heterogeneity in risk and resilience. And we can do that in Texas to round out my answer and say what we need to do in Texas.
Do we have any questions from the audience? Okay. Hearing none, let's go towards the end of the program. So I'm going to ask all of you to make a last thought statement for all of us. I'm going to start with you, Dr. Jacobson.
Yeah, I was just reflecting on some of this cancer analogy, which I think is kind of apt because we heard about the success of CPRIT earlier today. And I was reflecting on the fact that maybe Texas isn't seen as the bastion of neuroscience and neurotech yet, but it is for cancer, right? And I think that is a testament to the success of CPRIT. And maybe the question that I'm asking myself, and maybe you're asking, is can we do CPRIT for neuro, and will it be as successful as it was for cancer here? And I think we have the same ingredients, right? With cancer, we can take a test. We can figure out what subtype of illness you have. We can create a therapeutic designed specifically for that subtype. We have really smart people. We have a lot of sick people. Houston is the 4th largest city, so all types of mental illness are represented in the same way that all types of cancer are probably represented here as well. And those are the ingredients that we needed in order to develop a best-in-the-world cancer treatment center here in Texas. Those same ingredients exist for neuro. We're reaching the point we can take a test soon to figure out what type of mental illness you have. We can develop therapeutics specific for that type of mental illness. We've got a lot of smart people. We've got a lot of sick people. And so then what did CPRIT do that allowed us to turn those ingredients into success? It helped us recruit some of the best people in the world to come work on this problem by offering them a lot of money to help them develop that research program. We happen to be at a time when the federal government has just cut funding for neuroscience. So what better time to invest in recruitment packages for people outside the state of Texas than at a time when everyone's trying to figure out how they're going to keep their research program going. The second thing that CPRIT did that has been an incredible success was it helped to fund technology that had been developed in the mini institutions at that critical gap between where it was commercially viable or investable through companies like we heard from March. We have a lot of those nascent technologies here now, and it's the right time for us to think about helping them bridge the gap. So with just, I think, 2 types of investments, one in recruiting, one in helping to bridge the gap between concepts, a lot of the work that we've heard about today, and technologies, it seems like we can create in Texas a center of excellence in the same way we've been able to create one for cancer.
Thank you. Dr. Biggs? Any final thoughts? Okay. Dr. Lieberson?
Well, my final thoughts, exactly like my early thoughts, is I am always impressed by, when I searched in Texas A&M about people who have doing things with the brain, I found out that we had about 50 R1 funded investigators in Texas A&M doing brain. I didn't know that. They were not sitting in one department. They didn't sit in one there. Nobody knew that. That was an amazing. I see even more in that. I think we have the opportunities. We need put it together. We need focus this effort, both financial focus, but without that things don't happen, but also the need to create combined efforts to put our self-entity, because if 10 years from now, people will be asking, oh, what's the neuroscience center for Texas? And everybody will say, what? That will be a missed opportunity on a big scale. So to me, not to miss this opportunity is the critical thing, because we can be another Hopkins, another Stanford, another Broad Institute of Genomics in Harvard, or any other institute that we can be. We can be here, this center of neuroscience progress in general, but for Texas for sure.
You have something to say?
Yeah, I'll just add on to that. So I did my postdoctoral training at Harvard in Boston, and it was so impressive how everyone knew each other, everyone talked to each other. It didn't matter what institute you were in. And the way I find people here is by Googling or meeting people through other people, and it's been wonderful. They're fantastic people, brilliant people, but I think the more we can connect across institutions, the more powerful we'll be and productive, and it's an exciting place to be, and I think our job is to convince other people to come in, recruit talent, and build this, and I think we're starting to.
So with that thought that we need both mental and financial focus in Texas on this topic, we are going to end. And please give a big round of applause to our panelists. Thank you for attending, and thank you for joining. Thank you.
Thank you all very much for attending. Just put down. Yeah. So it's great to sort of hear from some of our researchers and clinicians on what they are seeing, and then of course looking to the future as well. So when we're thinking about all of these pieces and how they come together, one of the big focuses is of course on what does brain health and the economy of brain health really look like. So our next speaker is Dr. Harris Ayer. He is the Senior Fellow in Brain Health at the Baker Institute for Neuropolicy program at Rice University. He's got a background in medicine and neuroscience. Harris is really that policy entrepreneur, bringing all of the people together to discuss the path forward, both from profit, nonprofit, organizations, and government together. He is also a senior fellow for brain capital at the Meadows Mental Health Policy Institute and holds leadership positions at the Brain Capital Alliance and the Champions Cabinet of the Davos Alzheimer's Collaborative. So I'm going to turn it over to him to give his thoughts on brain economy and where this is heading for Houston.
Okay, let's talk about economics and leveraging economic power to drive more funding and more attention into the brain. That's what I want to propose to you. This is very left field, and I'm from Australia, so I'm always going to be left field. Like literally, that's where it comes from, even though I live in the US now. And that's a bad dad joke, and I have a little baby girl, so I'm allowed to make dad jokes. But I want to propose to you that you're all involved in this movement of the brain economy, and that Houston should lead the global brain economy. Just like Houston has led the energy transition, which is a very big, lofty economic transition that the world has gone through, and there's now a lot of competition in the energy transition. So what's Houston's next thing? I propose it should be the brain economy. So I'm going to extend on some of the remarks from our prior speakers and get into it. So the fundamental argument which Eric Mullins, the chair of the Greater Houston Partnership, said like super well, he heard me talking for like 15 minutes. He said, Harris, so the point of what you're trying to say is that our brains are in the red right when we need them in the black. We're dealing with major mental and neurological issues right when we need our brains to be successful and flourish in the modern economy, right, in the age of AI. I said, Eric, that's brilliant. That's the perfect sort of financial business person's description of what this is about. So that's my argument. Our brains are in the red, right? We need them in the black. So this is critical to the future of the Texas economy, is getting this right and driving forward this new brain opportunity for the Texas government. Brain issues are very big. The cost of mental and neurological conditions globally is 2.1 trillion per year, and this is rising at 5% a year. This is a problem that's on the scale of climate change. It's big and it's rising. It's getting worse. This is more than the U.S. spends on defense every year, and it's 2/3 of the gross national product of India. So this is big stuff. This data comes from the Institute for Health Metrics and Evaluation, which is a great partner. They have a brain health atlas if anyone's interested, and they've kindly provided me with some unique Texas data that I'll share today. So brain health is a major culprit of loss of health across the lifespan, right? From autism in kids through to Alzheimer's disease. But in younger populations, it's particularly acute, right? They say that 75% of these mental illnesses develop by the age of 24 or 25. So this is a big issue across the lifespan. So I'm putting in a point for mental health. But then when you look at the population structure of Texas from 1950 to modern times, you can see that we're aging, right? So Alzheimer's disease and dementia really comes into focus. So we really do need to think about this as a lifespan issue. And here's some interesting points that the demographic shift of aging in the US and globally, they say here, this is data from the IHME, is that Texas, is significantly rising when it comes to dementia over time. So this is data that was sent to me just a couple days ago, so it may be useful as we go through the political process here with the Texas government in the coming months. So this is a big issue for us in Texas. But let's not just talk about the cost and the dread and the burden. Let's talk about the brain as an asset. So asset-based thinking is something that I've liberally taken from the British. There's a few think tanks and The Economist are talking about health is an asset, not a cost. So I argue that our brains are an asset, not a cost. That is a hopeful message, and it changes the conversation. It gets business leaders and political leaders interested. Our brains are a driver of economic development ultimately. So that's again why you guys are all sort of the engine room of the economy of Texas in the coming decades. And so the top 3 brain skills that we need to be successful in the world of work as per the World Economic Forum are analytical thinking, creative thinking, and then resilience, flexibility, and agility. These non-cognitive skills are third. So there's this point, our brains are in the red right when we need them in the black, right when we need these skills. And as AI takes hold in the world of work and in schools and such, we really need these advanced skills to separate fact from fiction, to figure out how to be algorithmically literate, you could say. So what this gets down to is this new construct. It's a new economic asset. Think of it as like human capital 2.0. It's human capital in the age of neuroscience, brain capital. Brain capital is an asset that we need to see of as important as GDP and as important as road and bridge infrastructure. Brain capital is brain health and brain skills, so it's both of those things. So brain capital merges the health discipline with education and workforce. We need to build the brain capital of Texas. We need to build the brain capital of the US to be successful economically and to be secure as a nation, and frankly to have a thriving democracy as well. So I wanted to put in a point about how improving brain health in aging is critical to the economy. This is data from or a nice visual from the AARP. It shows here on the left that being social, exercising, eating healthy is associated with population benefits. It's associated with reduced dementia, reduced healthcare cost, increased brain capital, and improved quality of life. So this again is this way of linking brain stuff to economic stuff as we go into the next few months of justifying to our political leaders as to why we need to invest more in the brain and invest more in you guys. So the brain economy is this idea of moving from a brain unhealthy economic position to a brain healthy economic position. And we've been publishing on this with the World Economic Forum and really trying to push Texas leadership in the United Nations, the World Economic Forum, and in the federal government. And as I said before, Houston's the leader of the energy transition, where we've gone from fossil fuel-based energy sources to clean energy sources. So very analogous. Houston has the history, the muscle memory of how to do economic transitions. So how do we all work better with our economic development colleagues, with public policy, with business, and try to make ourselves relevant to them and work with them? How do we raise, billions and billions of dollars? And of course, we know that these other transitions, like the AI transition, the clean energy transition, these all need advanced skills. So we must have brain health to have a smooth transition of these other transitions. So again, you guys are you're at the heart, you're in the engine room of the way that the economy is changing. If we have way too much suffering and disruption and disability from mental and neurological conditions, people can't show up to work, to learn, to upskill and reskill. So I want to save some room for questions, so I'm going to skip through some slides. There are ways that we can measure brain capital at Texas. We have global approaches to that. There are ways that we can think through systems change, looking sector by sector at building brain capital in the first 1,000 days, in women's issues, in youth issues, in the environment, in digital. We all just saw actually Australia just banned social media for people under the age of 16. So that's another example. Who knows, if that's going to work. Interesting scientific and population health question. But anyway, you can make the point that systems change for the brain economy needs to look sector by sector. And again, we all need to think about this. We need to think about the role of architecture and built environment, and so on and so forth. I wanted to make a point about dementia prevention, but maybe I'll leave that to the next panel that's going to get more into that. Dementia prevention is eminently doable. There's wonderful work from the Lancet Commission looking at all of the different ways that you can reduce the risk of dementia over the lifespan. So if anyone's interested, or if that's useful from a messaging perspective or in these political discussions with regards to DPRIT, let's leverage the Lancet Commission. The AARP, the IHME, and the Alzheimer's Disease Data Initiative are looking at dementia risk reduction at the US level and also in Texas. So this is wonderful population health ways of justifying to public health people and politicians how you can drive down rates of dementia. At least 40% of dementia cases are preventable. And so this data is available. It was just launched last week, this project. So let's use it in the state of Texas to look at what percentage and how would we drive down dementia from public health interventions. And this is a bit more data in the context of Texas, but I'll keep moving. The workplace is really critical. The workplace is the engine of the economy and the brains of our workers, ourselves in our hospitals or in our universities or in businesses. It's critical. We have major issues with mental health. We have lots of workplace accidents. So moving neuroscience into workplace is critical. And so there's a wonderful new initiative called the Business Collaborative for Brain Health. We're doing an event in May with Shell at the Shell headquarters, where we'll be unpacking strategies and data approaches and toolkits for workers and how to do this. And even as Benham knows, we're thinking about the role of sleep in the workplace and how do we get things like neuroengineering innovations into the workplace, potentially for things like commercial pilots. There's some interesting work that we've done with McKinsey and Company around how do you justify and help human resource managers figure out if they should employ neurology innovation in their workforce, mental health innovation in their workforce, or well-being solutions in their workforce. And so what's the cross connection? HR managers getting very confused about where they should spend their dollars and what they should do. So there's some great work from McKinsey that I'm going to skip over pretty quickly in the interest of time. But how do you sort of figure out what are the common risk and resilience factors, and then what are the ways that these can benefit employees. So anyway, you get the point that driving into the workplace sector is another way where neuroscience can be very profitable to the economy, where we can employ ourselves in the interest of making workers more productive, more creative, happier, etc. I wanted to make a shout out to the Cancer Neuroscience Program at MD Anderson. Another reason why Texas and Houston can lead this neuroscience revolution is we have innovative programs like this. So if you haven't seen it, check it out online. It's just been launched, looking at the role of neurotoxicity of chemotherapy drugs, the biology of brain cancer, looking at the mental health consequences of cancer, as well as looking at the interesting ways that cancer cells can interact and move like neurons and have the biology of neurons. Industrial innovation strategy is also interesting. How do we develop perhaps an Operation Warp Speed for that we did for COVID vaccines? How do we do that in the brain? Operation Warp Speed massively pushed forward vaccine development and innovation by like 2 decades in the space of 18 months. So mental health and neurology need something similar. This is industrial innovation strategy. It's about how does the government help to fire up the private sector and philanthropy sector to drive innovation in a certain area. And there are examples in Canada of people doing this. Geriatric mental health in Canada has gone through a revolution, a renaissance because of CABI, because the Ontario and the Canada government got behind CABI and built it up, and now geriatric mental health is seeing a resurgence of startup activity. So let me move through here and just make my final point that I think Houston should lead the brain economy for these 10 reasons. We have perhaps the biggest neuroengineering presence globally. That's very unique and very special. We're leading in cancer neuroscience. We have the most brain stakeholders, brain scientists, brain doctors of any city in the world. And I think that's an accurate statement. We need to quantify that, but I'm pretty sure we have the biggest collection of brain area experts in the world. We're demographically the city of the future. And we also, as Jacob said, we have such a population that we have the patients suffering that we can help with studies and research. Brain-computer interface companies are clustering in Texas. Motif, as Jacob has founded, Neuralink, Paradromics, and Precision are either based in Texas or building fabrication facilities in Texas. So this is amazing. This is right on our doorstep. We have a supportive Chamber of Commerce, the Greater Houston Partnership. Is anyone from GHP here today? They're just wonderful, and they're on board with this journey, so that's terrific. We have expertise in the energy transition that we can repurpose. We have a supportive state government, as we know. One of our local congressmen, Morgan Luttrell, is a neuroscientist, and he's the co-chair of the U.S. government Congressional Neuroscience Caucus. This is very unique. Morgan loves to come to the TMC and support. And then, of course, we have risk-taking and visionary business leaders and philanthropy. So we have the ingredients to, in addition to what the prior panel said about the value of a DPRIT or something like that, we have the ability to drive this global economic transformation. And so I humbly propose that to you and invite you all to join on this journey to figure out how we're going to push this forward in Texas. So I'll stop there and maybe take some questions if we have a couple minutes left. Thanks. Let me just say then, we will be at the World Economic Forum driving this House of the Brain, and sorry this is a bit distorted. This is the big public-private think tank happening in Davos every year in Switzerland, and this happens in January. Yes, so if anyone's interested, contact. Yes, you had a question? Yeah, do we have a convention center big enough to host SFN? I'm sure we do. I think that's a great idea. We could put together a proposal to them. I love that. Yeah, very good. Yes. my favorite fact about the brain is that, because I'm a father of a little 14-month-old girl, my favorite fact is that I think that 90% of the size of the brain occurs in the first 1,000 days of the growth. So by the time 1,000 days passes, they have 90% of the brain volume. I think that's fascinating, and it speaks to the prior speaker, Professor Bick, about the value of supporting mothers, supporting fetal, maternal, placental exposome, and thinking about that, and then the first 1,000 days. Yeah. All right. Thank you.
Thank you. Yeah, that's perfect. Thank you very much, Harris. As he sort of talked about, which we will do a little bit in our wrap-up, but the importance of how we are bringing all of these together on Texas on a state level. And so that is a big piece of why we're here today, is gathering that awareness and getting ready for session in 2025. But now I'm going to ask the panelists to come forward for the next session. So this will be our last session of the day, but we really wanted to focus on it. There's so much when we think of neuro that goes beyond mental health and all of this, but the neurodegenerative, both in the development, the repair, and how all of these come together. So we have a great panel of 4 people, experts again from TMC, clinicians and researchers who are really leading the way in this space. So ask them to come up and we'll get started with this panel.
All right, well, look, we're on the way home, everyone, so stay with us. I'm Louise McCulloch. I am the chair of neurology at UT Health Houston. I am a stroke neurologist, vascular neurologist, and I will say vascular diseases are the second leading cause of dementia, following Alzheimer's, and contribute to Alzheimer's. I got to put a plug in for stroke. I study sex differences in the laboratory and also transgenerational health and the microbiome. But today, I'm not talking about any of my stuff because I am moderating. So I'm going to ask each of our panelists to introduce themselves sequentially in a few minutes, and then we'll get some discussion questions going. And I'm actually okay taking some things from the audience if anybody is interested. So why don't we start with you?
I'm Mirjana Savatic. I'm a child neurologist from Texas Children's Hospital and also a neuroscientist from Baylor College of Medicine. My clinical and basic science interest is in early neurodevelopment, and we study neurogenesis that actually is very important during development in utero because stem cells make our brains. But it's also important postnatally because this process occurs in all our brains in the Center for Learning and Memory. So we study how we can modulate this process to prevent or alleviate sense of aging.
Thank you. And to our UTMB colleague?
Hi, my name is Agenor Limon. I am originally trained as a chemist, pharmacobiologist. Then my fascination is how the brain works, how the electrical activity generates all the perception and sensation that we have, and how we respond to those. So during my training, I was working with sensory physiology, with the vestibular system in the brain, capturing biological data that can be used later for the programming of vestibular processes for microgravity in the space. Because in space, the vestibular doesn't work very well, so the eye don't work very well, and so on. But then all this information actually led me to see some of the gaps in how the brain works is associated with not knowing what is happening in the human brain at the synaptic or molecular level. So then I moved my interest to understanding what happens in dementia and in alterations in the synapses that Amy was before referring. So just to have an idea how these synapses are working, during the development, more than 1 million synapses are being made every single second. So during this time, so these synapses are very, very important. And those synapses in dementia and in all other neurodegenerative disorders are the principal target for proteins, oligomeric toxic proteins that are affecting those synapses. As long as we are as we are losing those synapses, then we have changes in cognition. So for that reason, I came here to UTMB 6 years ago in the Mitchell Center, and to understand how those functional changes happen in the human brain. So right now, I'm newly appointed to the director of the Mitchell Center and vice chair of neurology at the UTMB, and leading with those same efforts.
Excellent. Phil, from Methodist.
Thank you. Hi, everybody. I'm Phil Horner. I am a neuroscientist at Houston Methodist. I'm the director of the Center for Neuroregeneration, which is a group of researchers that are interested in coming up with new technologies, biologic and neurotechnologies, to repair the central nervous system after neurodegenerative disease, aging, and trauma and stroke. So my research interests, and one of the reasons I'm at Houston Methodist, is I was very excited about the potential intersection of neurotechnologies, particularly electrical stimulation, as a tool to promote plasticity. And so I'll tell you just briefly about why we're excited about it. The use of electrical stimulation is starting to gain traction. We heard earlier for mental health issues. And our particular interest is we're looking to restore somatosensory function in models of either spinal cord injury or stroke. And it's the one tool. I am relatively old, so I've been doing research for a while. And usually the things that I try in the lab don't work in terms of repair. But the one thing that's consistently worked for us is electrical stimulation. When we apply electrical stimulation in a model of spinal cord injury, we see improvement. It almost doesn't matter how we do it. So we've become extremely excited about looking under the hood and trying to understand the mechanism. So what's happening into the biology, which is, I think, the great strength of this region, particularly of Houston, is this intersection of our great engineers, neural engineers, neuroscientists, neurosurgeons, and neurologists, and the basic neuroscientists. We can bring these ideas together. The second thing that we're very interested in is something that I don't think has been talked about too much today, which is stem cell biology, and applying the tools of stem cell biology to create new circuits to replace lost areas of the brain. So if you have a stroke or spinal cord injury, you're going to lose circuitry, and no matter what we do rehabilitatively, we're not going to have full-minute repair. So our lab, in collaboration with many local laboratories as well as at national level, have been working on a technology where we take a patient's own skin cells and reprogram them to become neural circuits. And what's, I think, an exciting leap for us, and something that we hope to be the first to do in humans, is we've been able to take what we thought wouldn't probably work, which is to take a patient's cells and bring them back through development, produce neurons in a dish that are specific to a region of the spinal cord, make them very mature, and when you do that, you can transplant them into the nervous system and they survive. So this, to me, has opened up a really exciting area and concept for repair for multiple types of challenges to the nervous system.
Excellent. And have you made, and maybe this is for Mariana as well, have you made any progress in combining those two? For example, using electrical stimulation to enhance neurogenesis or enhance either endogenous or exogenous stem cell therapy. I'm not sure if you've done any of this. I know you've done some ex vivo work of cells on a chip and organs on a chip.
So the human models of disease are really the next generation of models that we can use to bring medicine to patients themselves. Because you can, as Phil said, you can use skin or blood cells from anybody and reprogram these little skin cells into their primary stem cell state. From those stem cells, you can develop any organ of interest. So we can develop lung and gut and liver, kidney, heart, including brain. So in our lab, we primarily work on these small mini brain organoids that we study in the case of neurodevelopmental and genetic disorders. But most recently, people have started to combine these different organs from the same person into something we call organs on a chip. So these are small platforms in which you can grow different tissues from the same patient and study how this tissue interacts with each other as if as when it interacts in our own body. So the electrical stimulation does increase the maturation of the neurons in these mini brains and increases the maturation in these organs on a chip. We also work with mouse models, particularly for aging and Alzheimer's disease type of dementia, those mouse models. And there we are very keen to stimulate production of endogenous neurons, neurons that are to stimulate stem cells that are already in the center of learning and memory, to start to produce more neurons to counteract those that died because of dementia. So in those cases, stimulation of not really the region where the stem cells are, but the region that provides inputs to this brain region, something that is a little bit outside, we call it entorhinal cortex. Stimulation of those areas does increase production of new neurons, and we are hoping that maybe with transcranial magnetic stimulation, sometimes we are thinking about this ultrasound therapy, which is now coming on board, or having an outside device that could sort of deliver these targeted stimuli into the local brain tissue to stimulate neurogenesis, maybe that would be one of the approaches to look in the future.
Excellent. And I know you've done a lot of things on GABAergic synapses. Can you tell us where you think the field is going? I know you've done a lot of Alzheimer's and neurodegenerative work. What do you see kind of going forward in the next few years?
So one of the important things, at least for cognitive impairment, is that we have imbalances in the circuitry. We have excitatory input that comes from the sensory systems, that comes from the internal mechanisms of generation of this electrical activity, but we have to balance that with inhibitory system. So this balance can go in both ways. If you have excess of excitation, you may have epilepsy, seizures, or you may have alterations in how you perceive things. If you have excess of inhibition, we go into coma. So actually, some of the things that produce cognitive impairment across many disorders are these imbalances of excitation and inhibition. And what happens actually in Alzheimer's disease is a very early affectation of inhibitory neurons. And we know that because there are many, many studies doing EEG, the prevalence of epilepsy in Alzheimer's disease. So actually that opens a window for treatments of electrical stimulation and helping those inhibition. But also another important thing that was helping to get that information is the large efforts that were done by the Allen Institute, that many years ago, we wouldn't believe that something as complex, we could actually see all the expression of genes of every single neuron in the brain. And the Allen Institute did this effort in combination with other groups. But right now, we know that there are 3,000 types of cells in the human brain. We know that how they are changing in Alzheimer's disease, and because doing these efforts that we need money to do also here, we were able, well, not we, but in general, the field, the field was able to understand which cells are very early affected. And because of these early affected cells, now we can actually, there are clinical studies where sensory stimulation or focus stimulation of the certain cells can help to bring that balance and reduce inflammation, reduce the production of toxic proteins in the Alzheimer's disease brain.
Excellent. Do you have anything to add, Phil?
Yeah, I just want to expand.
Yep.
So I think what Dr. Limon said that is really important is that we know the neural code, and we're starting to understand the rich diversity of neurons. So even within subregions of the nervous system, neurons which we thought were homogeneous are not. So, but knowing the neural code means that we can now, in the kitchen, we can cook up these neural circuits. And I think it's no longer, I mean, to me, it's an engineering problem. It's almost not biology anymore. And then I'll just touch on, I think that the use of some form of electrical stimulation or activity promoting system is going to be critical. So when we make neural circuits and we transplant them, you're going to have to do that. So if you think about in development, we all came out as babies, and of course we don't remember the first 5 years because our hippocampus wasn't working yet. But we didn't know how to walk, and it takes a long time to learn how to walk. And all of that is patterned electrical activity going through the nervous system until it's refined into a circuit that works for walking. And so we have the same issue in rehabilitation. People who've had a stroke or spinal cord injury. There are things that we can do. Electrical stimulation is promising, but the plasticity that we see is really slow. So I think one of the big frontiers is breaking that code. How do you make the nervous system grow quicker? How do you make neurons grow quicker? And we know some of the genes involved in growth rates and so forth, but I think this is a frontier in order to bring medicines like electrical stimulation really to the broader community. All of the people, as you know, so many people have strokes, right? It's one of the most affected communities, and it's one of the most expensive to take care of chronically. So I think it's super exciting time.
Yes, stroke is the #1 cause of disability in the US because often people don't die. There's hemorrhagic stroke where there's a very high mortality, 50% are dead in 30 days, and 80% of the remainder have deficits. And that's even a question. So an ischemic stroke where you have a thrombus or a clot can destroy much more brain than a bleeding stroke. And yet the bleeding stroke patients do so much worse. And if you look at their scans a year later and that blood has been cleared by microglia and macrophages, it looks not that bad, and yet the patient in front of you is so disabled. And I do think a lot of that has to do with exactly what you were talking about, that circuitry of the brain. It really is important. Use it or you lose it kind of thing. And that's one thing as we think about DPRIT and these hopefully potential plans to make a big investment in brain health, dementia, is really, if we think cancer is complex, think about the brain. And the brain does not operate in isolation. We heard in the earlier talk about how important it is for prevention. All these other factors, exercise, social isolation, stress, all these things affect brain health. How do they do it? So one of the things that I think is becoming very apparent is also inter-organ communication. If you have liver disease, then you develop delirium and you have worse brain health. If you have, and we're also starting to understand how the bone marrow, especially of the skull, communicates with the brain. I don't know if you want to pick up on that, Phil, and we can go
No, I think that this is huge. I think, so we've been talking a little bit today, how can Texas be leaders? How can Houston be leaders in neuroscience? And I think, to me, the most obvious thing is just what you said, Luis, is that the brain is connected to all the peripheral organs, and it's a system, right? So we're walking around. We can't quite upload, maybe Jacob will do it later, but we can't upload our brains into the computer system or into a robot. So our bodies are incredibly interconnected. And if you look at the really rich, it's like $2.4 billion in NIH funding comes to the state of Texas in vascular biology, cancer biology, immunobiology, and all of those systems. We think about the potential to leverage the neuroscience that's here in neuroengineering with researchers who study these peripheral systems. You have a great example. I love the liver example. So if your liver becomes inflamed, right, you can develop a very specific type of dementia. It's also true that dementia affects your peripheral organs, right? Spinal cord injury, if you have a spinal cord injury, one of your biggest concerns is restoration of bowel and bladder function. Well, a neuroscientist isn't going to solve that problem without people who both know the central nervous system, peripheral nervous system, but also the end organ systems. I think that's a huge opportunity for us and an investment in Texas where we can be the leaders in sort of systems neuroscience.